Good day, everyone, and welcome to Module 10. Infection Control in Wound Care. Infection is one of the most serious complications in wound care. It not only delays healing, but can escalate to systemic infections and even lead to amputations or death if not managed effectively. In this module, we'll focus on the practical knowledge and clinical skills you, as nurses, need to identify, prevent, and manage wound infections confidently and efficiently. By the end of this session, you will be able to 1. Describe the microbial burden spectrum, from simple contamination to severe systemic infection. 2. Recognize the signs and symptoms of both local and systemic infections. 3. Apply aseptic techniques and use infection assessment tools such as NERDS and STONE-EASE. 4. Select appropriate topical and systemic antimicrobial treatments. 5. Understand the role of biofilm in delaying healing and how to counter it. These are not just theoretical points. They are key to improving patient outcomes and preventing avoidable complications. Let's start with why this topic matters. Wound infections are a major cause of prolonged hospital stays, increased healthcare costs, and greater patient morbidity. Infected wounds can deteriorate rapidly, leading to sepsis, limb loss, or even death. Many infections are preventable with the right practices. As nurses, you are the first line of defense. Your observations, wound care techniques, and decisions directly influence whether a wound heals or becomes chronic and infected. This module equips you with the tools to make those decisions quickly and accurately. Understanding infection begins with understanding the microbial continuum. Not all bacteria in a wound indicate infection. Let's walk through the stages. 1. Contamination. A. Non-replicating bacteria are present. B. No signs of inflammation or infection. C. No treatment is required. This is normal. Second, colonizations. A. Bacteria start replicating but aren't harming tissue. B. Wound may still heal. Continue with standard care and hygiene. Third, critical colonization. Healing begins to slow down or stop, though obvious infection signs may be missing. B. This is where topical antimicrobials can help prevent worsening. 4. Local infection. A. Now you'll see clear signs. Redness, swelling, increased exudate, odor. B. Use both topical and possibly systemic antimicrobials. 5. Spreading or systemic infection. I. Infection spreads beyond the wound, maybe fever, increased heart rate, fatigue. B. Requires urgent intervention, IV antibiotics, hospital care, maybe surgery. Also, biofilms, slimy communities of bacteria, can form at the colonization stage. They shield bacteria from antibiotics, making treatment difficult. Management includes sharp debridement and antibiofilm dressings. Let's talk about the culprits, the microorganisms most commonly found in infected wounds. Staphylococcus aureus, including MRSA, which is resistant to many antibiotics. Pseudomonas aeruginosa, common in moist wounds and burns. Gives off a greenish discharge and fruity odor. Enterococcus species, often found in surgical or pressure ulcers. Escherichia coli, E. coli, typically from contamination due to poor hygiene or fecal matter. Anaerobic bacteria, like Clostridium, often involved in deep necrotic wounds with foul odor and gas formation. What makes these infections harder to treat? Most chronic wounds are polymicrobial. Multiple organisms are involved, and many of them form biofilms, which reduce antibiotic effectiveness, prolong inflammation, make wound healing very difficult. Understanding the type of pathogen helps guide treatment, especially in choosing the right antibiotic or antimicrobial dressing. Let's talk about how to recognize an infected wound early, because catching it late can lead to serious complications. Local signs of infection include redness that extends beyond the wound margin, swelling, warmth, and increased pain, exudate that becomes thick, discolored, or foul-smelling, delayed healing or deterioration of the wound bed. But not all infections look dramatic. Sometimes subtle changes are the earliest clues. This is where assessment tools come in. We use the NERDS tool for superficial infection, non-healing, exudate increase, red wound bed, debris in the wound, smell. If 3 or more signs are present, it's time to consider topical antimicrobial therapy. For deeper or systemic infections, use the Stoney's tool. Size increase, temperature elevation, local or systemic. O's, meaning exposed bone or risk of osteomyelitis, new satellite wounds or breakdowns, erythema spreading, exudate heavy or purulent, smell strong or putrid. Presence of 3 or more Stoney's, signs warrant systemic antibiotics and urgent intervention. These tools help structure your observation and ensure timely, evidence-based escalation of care. When visual signs aren't enough, laboratory and imaging tools guide our clinical decisions. Start with wound swabs, but be selective. Use the Levine technique. Press a swab into healthy granulation tissue for 5 seconds after cleaning the wound. This reduces surface contamination and improves accuracy. Tissue biopsies or aspirations are the gold standard, especially for chronic or non-responsive infections. Blood work is also crucial. WBC count, CRP, and ESR are elevated in systemic inflammation. If fever or fatigue are present, don't ignore these markers. Imaging is required when you suspect deeper involvement. X-rays can reveal gas in tissue or bone erosion. MRI detects osteomyelitis, deep abscesses, or foreign bodies. Remember, no lab result replaces your clinical judgment, but used together, they sharpen your diagnosis and direct your treatment plan. The most powerful defense against infection? Prevention. And prevention starts with aseptic technique. Hand hygiene is non-negotiable before and after every patient contact. Use sterile gloves, especially for deep or open wounds. Clean the wound from least to most contaminated areas, usually from the center outwards. Environmental control also matters. Prepare your workspace, disinfect surfaces, and organize materials before starting. Use sterile, single-use dressings whenever possible. Avoid placing open dressing packs on unclean surfaces. Protective barriers, like gowns, masks, or goggles, are essential when dealing with infected or high-risk wounds. And finally, training your entire care team in these practices ensures consistent infection control. It's not one person's responsibility. It's a shared commitment. Once an infection is diagnosed, we must treat it decisively but appropriately, based on the type and depth of the infection. 1. Topical antimicrobials. Ideal for local infections or critical colonization. Examples: silver-based dressings, iodine, PHMB, and medical honey. Apply for 7 to 14 days max to prevent toxicity or resistance. 2. Biofilm management. Biofilm acts like a slime shield for bacteria. Sharp debridement is key, done weekly or more. Use cleansers with surfactants, antimicrobial gels, or even low-frequency ultrasound to disrupt the barrier. 3. Systemic antibiotics. Necessary for deeper infections. Stoney's positive cases. Start broad spectrum, then refine based on culture results. Monitor renal and hepatic function closely during antibiotic therapy. Route depends on severity, oral for mild, IV for serious cases. Important: never use systemic antibiotics for colonization alone. It leads to resistance and harms the patient. 4. Advanced interventions. Incision and drainage if abscess is present. Negative pressure. Wound therapy, NPWT, for heavily exudating or deep wounds. Surgical debridement for necrosis or heavy biofilm. Consider HBOT, hyperbaric oxygen therapy, or vascular surgery in ischemic wounds. Managing infections isn't about one size fits all. It's about matching the treatment to the infection stage and depth, with precision and urgency. As nurses, you are central to infection control, from first assessment to final dressing. Here are your key roles. Assessment. Constantly monitor for signs of infection, wound progression, and dressing performance. Dressing selection. Choose dressings that match the level of infection and exudate, antimicrobial, moisture retentive, or absorptive as needed. Documentation. Meticulously record wound characteristics, signs of infection, interventions, and patient response. Collaboration. Communicate findings to the wound care team, infection control, and physicians. Education. Teach patients and caregivers about hygiene, proper dressing techniques, and importance of medication compliance. Nursing vigilance saves limbs, reduces hospitalization, and empowers healing. Let's wrap up with key takeaways. Infections delay healing, increase costs, and threaten lives. Understanding the microbial continuum, using tools like NERDS and StoneEase, and applying targeted treatments help us intervene early. With aseptic techniques, accurate assessments, and evidence-based management, we can control infections before they spread. And with consistent nursing leadership and patient education, we can improve outcomes and quality of life. Thank you for being the frontline defense in wound care. Your work saves lives every single day.